Hi, everyone. We're going to get started in just a moment. We're going to give people just another minute to sign on. So welcome to the webinar, Breast Cancer 101, What You Need to Know. I'm Christine Benjamin, Senior Director of Patient Services and Education at SHARE. Before the presentation begins, I'd like to tell you just a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who've been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Comen finishes presenting, we'll begin the Q&A discussion. You're welcome to submit questions during the presentation through the Q&A section on the bottom of your screen. The chat section will be disabled. When asking questions, remember that Dr. Comen is unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. So now I'd like to introduce our speaker. Dr. Elizabeth Comen is a medical oncologist on the breast medicine service at Memorial Sloan Kettering Cancer Center with a clinical practice devoted to treatment of patients with all stages of breast cancer. She's also an assistant professor of medicine at Weill Cornell Medical College. Dr. Comen earned her BA from Harvard College and her MD from Harvard Medical School. She completed residency at Mount Sinai Hospital and her fellowship at Memorial Sloan Kettering Cancer Center. She has presented her research many times at the American Society of Clinical Oncology, at the annual meeting, and also at the San Antonio Breast Cancer Symposium. She has also been awarded several peer-reviewed grants, including the Young Investigator Award from the Concord Cancer Foundation of ASCO, Breast Cancer Breakthrough Award from the Department of Defense, and the Lambert Foundation Award from the Breast Cancer Research Foundation. Welcome, Dr. Comen. Thank you so much for being here. It's so good to see you again. You're so generous with your time and helping us to educate our constituents at SHARE. Thank you so much.
My pleasure. So full disclosure, which is that I thought I was originally going to talk about like the latest updates in breast cancer, but now I understand it's also just the lay of the land with breast cancer. So I think what we can cover today is what is breast cancer? And then I'm going to tie that into some of the newer advances that we know about today. But I'm excited about the Q&A as well, because that's always a great way to kind of launch into what people are interested in. But thank you for that introduction, and let's just do it. I don't have slides or people with slides. So while you were talking, I actually drew some pictures, some little cartoons of things, which I hope is helpful. So let's just talk about what breast cancer is. And the thing when you think about the history of medicine and certainly the history of how cancer has been labeled is that, oh, wait, I see a picture of a dog with a mask. Amazing. Okay.
That's just my photo.
I like it. I like it. You're hairier than you usually are. All right. So when we think about what we talk about breast cancer, it's really just one cell in the body. It starts as one cell that has started to grow awry. And there are lots of different reasons why that one cell, whether it's in the breast, whether it's in the lung, if it's lung cancer, whether it's in the kidney, it's kidney cancer, has started to grow awry. And the whole field of oncology is really to understand what allows that one cell to grow into 2, to grow into 4, to grow into 8, and essentially multiply and ultimately form a mass. And in some instances, masses that can then spread. So one cell, what gives it the capacity to grow and divide, and then also what gives the capacity of a cell to not only move from its homeland, from its home site like the breast, but potentially break off and have legs to travel. I think about it like what gives a cell a passport to move from its original home. And so when we think about breast cancer, I think it's really helpful to, here's my little crude diagram. All right. And we can always load slides if that's easier. But what I've shown here is a side view of a breast. So a breast that's cut in half. The red nub that you see over here is the nipple. And then you'll see kind of what looks like a squiggly sac right over here, right over there. And those are what are called the lobules, okay? And that's where milk is made when a woman is lactating. And then that milk would travel out through the ducts, which are the sticks that you see traveling out down through the nipple, right like that. And so I show this figure because it's really essential to understand how and why breast cancer forms. So the two big places that breast cancer can form are, one, those lobules, that green sac, squiggly sac that I drew there, and then the ducts. So the ducts in which milk could travel out through the nipple. Now, women have this architecture of their breast from puberty on, and you don't have to be pregnant or lactating in order to have those lobules there. And so the two most common places that women, I mean, there are some rare pathology that women can have, but for the most part, breast cancer starts in either the lobules or the ducts, okay? Now, when it starts in the duct, I'm gonna draw you a picture. This is what a normal duct looks like, okay? It should be hollow on the inside. And what I've shown here, and I didn't have time to continue drawing it, is those are just green cells. That's the bricks that form the shell or the tubing of the duct. So it should be hollow on the inside, and the normal breast duct should just be filled just to make the duct. It should not grow inside and not should grow outside. But sometimes what happens is one of those green cells can start to grow awry. And breast cancer really happens on a spectrum. It's not as if it goes from a normal cell to an abnormal cell overnight. That's not how it works. What happens is a growth over time. And obviously for some patients that can happen faster or sooner. But what the classic example of how this works is the cells start to grow inward. So you can see here on the inside of that duct that some of those cells have started to grow inward. And when it starts to grow inward, that's what we call ductal carcinoma in situ, meaning the cancer cells are in place, in situ. And I said cancer cells, but they're not actually cancer cells, they're abnormal cells. And one of the things that gets complicated when we think about DCIS is a lot of people refer to it as cancer, but really what defines cancer is the ability to grow and divide and move. And these cells, when they're just growing on the inside, they're contained. It's not considered invasive. It's not considered anything that would affect a woman's survival or their breast in any meaningful way, provided that those cells never move. And the reason why we treat ductal carcinoma in situ, and why some people even refer to it as an early stage cancer, is because what happens is over time, I'm gonna try to turn it this way, those cells that were growing on the inside and the wall ultimately can move and break away what's called the basement membrane, the outer layer of the duct, and start to move outward. And when cells start to move outward and leave the primary structure in which they started, that's what we call invasive cancer, okay? And that's what we call invasive ductal carcinoma, meaning the cells have been able to break through that wall and move beyond the structure in which they started. And so when we think about breast cancer, the two main types, again, invasive ductal carcinoma or invasive lobular carcinoma. And the lobular or the ductal just refers to the geographic place in the breast in which that started. So when we think about breast cancer, we first identify underneath the microscope, where did these cells start? What sort of abnormal architecture is there? And then we look at three other main receptors. The first receptor is the estrogen receptor, and that usually goes along with the progesterone receptor. These are the receptors that feed and use female hormones, estrogen and progesterone in the body to help a cancer grow. So you'll hear a lot of women, diagnosed with estrogen receptor positive breast cancer. About 2/3 of breast cancers are estrogen receptor positive breast cancer, which means that they needed estrogen or progesterone to grow. And often if you have one positive, like the estrogen receptor, then the other one is positive as well. They go hand in hand. Not always the case, but often the case. And then we think about the HER2 receptor. The HER2 receptor also sits on the outside. So let me draw one other picture. So now I'm zooming in on one of those green bricks that we talked about, one of those green cells. And so if we think about that, there are these three different receptors on the outside. You can have the estrogen receptor, the progesterone receptor, and the HER2 receptor. So what happens is the pathologist looks underneath the microscope to decide what percentage of these cells actually have any of those receptors there. So if you hear about triple negative breast cancer, what that means is that that a woman did not have any of those receptors on the outside of their breast cancer. You could also be any combination of the above. You could be estrogen receptor negative, progesterone receptor positive, and HER2 positive, or positive or negative in any direction of those three receptors. So again, those are the two big categories of things that we look at. Is it ductal or lobular? Where did it start? Is it estrogen receptor, progesterone receptor, or HER2 receptor positive? And then the other thing we think about with early stage breast cancer, and we can talk about metastatic later, is whether the lymph nodes underneath the armpit are involved. And this becomes important for helping to determine whether a woman needs chemotherapy and how we treat it moving forward. So I'll take a little pause right now. If anybody wants to enter any questions, I could start to answer questions. Otherwise, I'm just going to keep going forward. So once we have a sense of the biology of a cancer, then the next question is, well, how do we manage it, right? And most patients who come to me have come either at the time of meeting a surgeon, or they may have already met a surgeon. So if we have the basic understanding that a cancer starts in the breast, the next thing we want to look at is whether it's evolved to involve any of the lymph nodes. And so when a woman has seen a surgeon up front and had surgery up front, they've either had a lumpectomy or a mastectomy, plus what we call a sentinel lymph node dissection or an axillary lymph node dissection. Now, when on clinical exam, when we're feeling the lymph nodes and we're looking at the breast, or on imaging, if it doesn't look like there's any lymph nodes involved, when we either palpate them or look with imaging, then the next step is usually what we call a sentinel lymph node biopsy. A sentinel lymph node biopsy is when we inject one area of the tumor in the breast and see which is the first draining lymph nodes. That's what we call the sentinel lymph node, the guarding lymph node. And that helps to tell us if that lymph node isn't involved by cancer, then it's unlikely that the others are going to be involved as well. And that's been a key advance in terms of how we do surgery for breast cancer patients, because traditionally, historically, we might remove all of their lymph nodes in the armpit when maybe that was unnecessary. Now, other women may need what we call a full axillary dissection, where we take out all those, as many lymph nodes as possible underneath the armpit, because either on clinical exam, when we feel or when we look and we biopsy something that we see in the armpit on imaging, we end up finding out that a woman already has cancer in her lymph nodes there, and that's when it needs to be more fully operated on. So we've talked about so far the different types of breast cancer, geographically where they can start in the breast, the duct or the lobule, the different receptors that are outside on the cancer cell, the different types of surgery that a woman may have, which is sometimes either just to remove the lump and perhaps just do a sentinel lymph node biopsy, or in some instances, a woman needs a mastectomy and more complete axillary dissection. And you can have any combination of the above. Another way that we have to think about treating breast cancer is not just the local control, but what we refer to as systemic control. So local control refers to what we do to contain and stop the breast cancer from growing in the breast itself. So how we do that is surgery, either a lumpectomy, a mastectomy, and whatever surgery a woman needed under her armpit. And then we have to, in some instances, combine that with radiation. So if a woman gets just a lumpectomy, then we do almost always, unless she's over the age of 75, we almost always partner that with radiation. And that has the same survival as doing a mastectomy for breast cancer, okay? So radiation and surgery are our two mainstays for local control. So what's the other type of control that we talk about? And that's really where a medical oncologist comes in. The other type of control that we talk about is what's called systemic control. Systemic control refers to, well, how do we anticipate or calculate or treat the idea that sneaky cancer cells, even if lymph nodes are negative, can sometimes bypass the lymph node, gain a passport in ways that we're still learning. And I know there were questions up front that many of them will play into what I'm talking about right now. that give cells the passport to move from where they started. So imagine a house and you've got these misbehaved, I hate to refer to kids as cancer, but I love my kids, but imagine you have these mutant aliens that in alien family, they're not even human, okay? An alien family, and the little mini aliens are growing and growing and dividing, but they never leave where they started from. Well, if we imagine those as breast cancer cells, that might look weird, and the breast might feel lumpy and bumpy, but if those little aliens never traveled, if they never had a passport, if they never had spaceships to move to other planets or other parts of the body, then it wouldn't affect a woman's potential survival from cancer. In this instance, what we really try to determine, and where the science is really growing, is what allows those cells in some instances to travel. We have newer abilities to predict this and help us figure out how we manage that. And I'm going to talk about that in just a moment. So one of the ways that we deal with what we call systemic control is chemotherapy. So who in general needs chemotherapy? Chemotherapy usually goes through an IV. In some instances it's pills, but it's almost always an IV that we give a woman either before or after surgery if we're talking about early stage disease. And the purpose of chemotherapy is to go after any cell that seems like it is growing and dividing very quickly. And we know from decades of research that this can significantly improve a woman's outcome from breast cancer. But one of the things that's really interesting and new that's come up, and this is what I wanted to talk about today, is one of the tests that we use is Oncotype. And Oncotype is a test where we take a biopsy of the tumor. We take a little piece of the primary breast tissue that where the cancer started. We take a piece of it, we send it to a lab, this Oncotype lab in California, and it looks at 21 genetic switches. These switches tell us how much metastatic potential a cancer might have. What is the capacity of the cancer cell to spread? How bright was that light? How great was that passport versus how dim was that light? And how bad was the passport of the cancer cells to move? And you get a score. And that score can be either high or low, and we have different cutoffs. So one of the things we learned several years ago was that women over the age of 50, if they had a score of under 26 on this special score, Oncotype score, then they didn't need chemotherapy. Then the only thing that they needed, and I'm sorry, I should say that this was only for estrogen receptor positive breast cancer patients, so patients who had cancers that needed estrogen to grow. What we learned was that so many women could avoid chemotherapy and proceed with hormone therapy alone. And hormone therapy alone is pills. We talk about tamoxifen, aromatase inhibitors, depending on where a woman is in her menopausal status, to block the ability of estrogen to stimulate a tumor. So that's another form of systemic therapy. But the Oncotype point was really, really key, because we found that a vast majority of women, particularly over the age of 50, with these lower Oncotype scores, no longer needed chemotherapy. Now, that was not the case necessarily for younger premenopausal women, where the scores and the cutoffs were slightly different for when we were able to say, you know what, you really don't need chemotherapy. But just this past year, and I see that there looks like, okay. And just this past year, there was another study that came out called the R-Exponder trial. Now, the R-Exponder trial was really an essential study that really showed that many postmenopausal patients with node-positive breast cancer that were estrogen receptor positive, so they had tumors in their breast, they had lymph nodes involved, and they had this Oncotype test score calculated based on their tumor. And they looked at thousands of women, over almost 10,000 women with what we call stage 2 or stage 3 breast cancer. That just refers to the size of the tumor and the number of lymph nodes involved. And they looked at women with scores of under 25 on this Oncotype test. And what they found, that these women with these lower scores, under 25, who are postmenopausal, did not benefit from chemotherapy. So this is huge. It tells us that when we do just hormonal therapy alone for these patients, that they actually do just as well than patients who are getting chemotherapy and hormonal therapy. Their outcomes are largely very, very good, and we can avoid the toxicity of chemotherapy. Now, this was not true for premenopausal patients. What we learned was that premenopausal women, if they have lymph nodes involved, still absolutely do need chemotherapy. So taking a step back, we've talked about recapping where the tumors start, the biology behind them, the concept of local control, which refers to surgery and the types of surgery that we do. And then we talked about what a medical oncologist does, which is systemic therapy. And systemic therapy can be chemotherapy, and there are different indications for that. We know that the guidelines for that just changed based on this Oncotype score if a woman is estrogen receptor positive. But there's some other nuances. So the Oncotype test really only refers to women who are estrogen receptor positive. What about women who have triple negative disease where they don't have any of those receptors? The mainstay of chemotherapy, or of the mainstay of treatment for those patients, is almost always chemotherapy, unless it's very, very, very small. The other thing you need to know is that if a woman is HER2 positive, so they have one of those HER2 receptors or many of those HER2 receptors on the outside of their cancer cell, then they need something called Herceptin, or in some instances pertuzumab, which is a drug that helps to target specifically that HER2 receptor. And that is almost always combined with chemotherapy, and there are different chemotherapy regimens that we use for that. But the extraordinary thing is that HER2 positive disease used to be one of the cancers that we thought of as the most aggressive breast cancer. But now with the advent of Herceptin and pertuzumab, it's entirely changed the landscape of how we treat breast cancer patients. So systemic therapy, we talked about local control, systemic therapy, chemotherapy, with or without Herceptin or pertuzumab, depending on if somebody is HER2 positive. If they're triple negative, they almost always get chemotherapy. And if somebody has a high Oncotype score, or they have lots of lymph nodes involved, we're talking about using chemotherapy for them. And that's really the big gestalt of how we deal with breast cancer in the early stage setting. When patients become, if they become metastatic, meaning cancer has spread to other parts of their body, that's when it becomes really important to, again, look at the biology. So if a woman has breast cancer that has grown in her bones or in her lung, we always want to stick a needle in that. And not every hospital does that. We want to stick a needle in it, look at it under the microscope, and really try to understand how similar is it to the original breast cancer that grew? What are some of the mutations that may have arisen in that cancer to help it grow? Most often we, particularly with estrogen receptor positive breast cancer patients, we try to avoid chemotherapy because most often those women will benefit from just hormone therapy alone, particularly in the beginning. So one point I'd really like to say, if anybody is listening and has metastatic disease, it's so important that the tissue be biopsied so that we can understand why and how it grew. I want to touch upon, now we have sort of the breast cancer 101 gestalt, some of the later advances of this year. So first I want to acknowledge, I know there are probably some questions about the vaccine. So, COVID has really, for the most part, been absolutely horrible, right? There's almost nothing good we can say about this COVID pandemic, but there is one thing that has happened, which is that we've all learned how to work better together internationally and virtually, and pool our resources together. So if we look at how quickly this vaccine has come up, now COVID is really just one disease, and we know that breast cancer is very, very different depending on the cancer patient, and certainly cancer itself is not just one disease, but many, many, many diseases. But we'd like to think that we can use this as a model for how we can really, really come together as scientists, as clinicians, as physician scientists, to see how we can use some of the techniques and the resources to advance science forward in the same way. When it comes to using the vaccine, I would say to anybody listening, if you can get the vaccine, get the vaccine. We are aware that some patients are in the middle of chemotherapy, and the guidelines really say, talk to your doctor about what chemotherapy that you're getting. But for the most part, as long as you're not getting chemotherapy on the same day or around within a few days when your counts may be lower from having gotten chemotherapy, that it should be absolutely no problem for you to get the vaccine. Now, obviously, we want to be able to vaccinate everybody, and New York has been a bit of a disaster, as has the whole country been in rolling out the vaccine. But as the age is starting to lower for when we can offer the vaccine to patients, I would say do whatever you can to get it and ensure that you're vaccinated. It's certainly safe for breast cancer patients. And one of the other things that sadly has come out of this pandemic, though, is that we've seen a lot of patients delay their care. So between March and April, at the start of the pandemic, I think through till May, the number of breast cancer diagnoses went down almost 52%. And that's not because there was less breast cancer, it's because people were afraid to see their doctor. And we're very, very concerned about the fallout of people not getting mammograms, not going to their doctor. I've seen many, many people with very advanced disease over the last 6 months because they were afraid to leave their home. And I think one message that I really want to impart to everybody today is that first, we know it's incredibly challenging to be dealing with a pandemic, let alone cancer in the middle of a pandemic. And so it's really essential that you know that hospitals are safe now. We double mask, we wear face shields, where majority of us are vaccinated, and you will be screened and checked beforehand. And we don't want people avoiding care because they are afraid of coming to the hospital. I want to touch upon some other advances this year. So many of you may have heard about a study called Monarch E. This was a study that looked at a class of medications called CDK4/6 inhibitors. These are medications that we classically use for metastatic breast cancer. They work synergistically with hormonal therapy to decrease the risk that a hormone receptor positive breast cancer could grow. And there is data to show that a drug called abemaciclib may be helpful to women who had high risk but not metastatic estrogen receptor positive HER2 negative breast cancer. So high risk meaning they had a very large tumor in their breast or a lot of lymph nodes involved. And when these women, as part of a clinical trial, were given a drug called abemaciclib, or otherwise known as Verzenio, women seem to do better over time. Now, the drug is not yet approved for this setting, but that is really something to look out for and talk to your doctor about over time. A couple other things that really came up. I take care of women of all ages, but I do have a number of young women. We learned that women who go on to get pregnant after having breast cancer, and we've learned about the timing of that, really seem to do just as well as the average woman. Their babies were just as healthy. In some instances, they were more likely to have a baby that was smaller for gestational age, but they were not more likely to have congenital deformities, miscarriages, or any other delivery complications. And I think that that's really important. So especially for any newly diagnosed young women being diagnosed with breast cancer right now, it's really important that they be referred to a reproductive endocrinologist to talk about fertility treatments. We know that they don't increase the risk of breast cancer recurrence, and we would always want a woman to be able to maintain her ability to have a child one day, should that be something that we wanted or something that she wanted. Other things that I wanted to talk about, and I know there's probably some research questions. One area of research that has really evolved in the last few years is the concept of using the immune system to fight a breast cancer. So a couple new trials came out this year looking at immunotherapy for tumors that needed what we call neoadjuvant chemotherapy. Adjuvant refers to after surgery. Neoadjuvant refers to before surgery. And so their larger tumors often need chemotherapy before surgery to shrink the tumor. And there was a study called Keynote 522 in which evaluated the concept of giving neoadjuvant chemotherapy plus an immunotherapy, so something to stimulate the immune system to fight the cancer. And what we found is that women who received the immunotherapy, their tumor in their breast shrunk more. And there was another study as well called Impassion 031 that looked at atezolizumab, which is a different type of immunotherapy, but same type of context in the neoadjuvant setting, meaning before surgery. And the reason why this is important is when you shrink the tumor in the breast, the assumption is, but we don't know, that women will do better over time, meaning that they are less likely to have a risk of what we call metastatic disease, where the cancer spreads from the breast to another part of the body. Now, the data is not yet mature. We don't know for certain that giving these immunotherapies early on in disease will actually improve survival from breast cancer. And so those drugs are not yet approved, and we're waiting for more data to make sure that it really helps patients, because immunotherapies are not without potential toxicities. Anytime you introduce a new drug, there's more potential side effects. And so these drugs are primarily used right now in the metastatic setting for women who have what's called triple negative disease. Again, none of those receptors on the outside of their cell. And so for metastatic disease, drugs like pembrolizumab and atezolizumab, which are immunotherapies, are approved for triple negative disease, but this is for women who have a much greater burden of disease. And we're still learning whether it might benefit women with early stage breast cancer. A couple other things that we learned this year is that just as I talked about younger women, we can't forget that older women, sometimes there's a lot of ageism that goes on where we just look at age and figure, oh, they're too old to receive X, Y, and Z chemotherapy. And we know that particularly for triple negative breast cancers or women who have lymph nodes involved and a higher oncotype score, that they may actually benefit from giving chemotherapy. And we don't want to not give a woman chemotherapy if it's seemingly safe for her and she does not have any other significant medical problems that would make that concerning for us. I want to touch on metastatic disease and then cover some of the questions that people asked. And I think there may be, can I discuss, these are great questions. So let me just take a pause for a second. Microcalcifications are a little bit complicated because, so if somebody asks, can you just assess microcalcifications, please? That's something that we see on radiologic imaging. It's really better answered by a radiologist, but calcifications can be totally normal, but they can also be an area where we see on a mammogram that prompts the radiographer to say, we need to biopsy that. So again, calcifications can be, again, totally normal. They can be associated at times with having lactated, and other times they need to be biopsied. So it really depends on the person. But then there's another great question. Have there been any updates with science relating to Black and white women with breast cancer? So before I go over some of the other questions, I really want to address that one. So first of all, taking a big breath here, the COVID pandemic has highlighted the tremendous inequities in our healthcare system that sadly in too many areas fall along racial divides and also along poverty divides. And in many instances, those two sadly combine. And so what do we know about different rates of Black women versus white women in terms of breast cancer? So very interestingly, if we look at the absolute incidences of breast cancer among Black women versus white women, it is not that different. What is staggeringly horrible is that Black women are 40% more likely to die from breast cancer than white women. And the reason we believe for that is, yes, there can be some differences in the biological subtypes that Black women may be more likely to be diagnosed with, such as triple negative breast cancers, which can be more aggressive. But when we look at the data, probably what all of this amounts to is that Black women have less access to quality hospitals, or less access to mammograms, less access to insurance, less access to care like an academic center where they might be seen in a timely fashion. They may have a mammogram 1 month and not be able to get a biopsy 2 months later. And one of the things that we know that if women don't have all their treatment within a 38-week time period, that can significantly decrease their outcomes. So there's huge discrepancies and much work to be done. And when we look at also providers, only about 2.6% of oncologists are Black. That's a real problem when we don't have our healthcare force, our doctors, reflecting the diversity in our community. So one of the efforts Memorial Sloan Kettering is doing, and I know hospitals across the country, it's not just about recruiting, residents and fellows and attendings that are Black. We really have to encourage people very early on about the sciences and about a passion for taking care of breast cancer patients. I became involved and interested in this when I was a freshman in college, and that really, I had a lot of people along the way who encouraged me, and we need the same for our Black students and minorities so that our healthcare system can reflect the needs of our society. I have another question here. So
if you
there's,
look at
yeah, one of the other questions is very specific and personal. That one's a little bit harder for me to answer, but one question I think that often comes up is whether women should have their ovaries removed if they've had a history of breast cancer. So to clarify on that, so if a woman has a known hereditary mutation, such as a BRCA1 or BRCA2 mutation, then it's very important that you speak with your surgeon about your oncologist and gynecologist about when might be an appropriate time to consider taking out one's ovaries. So those mutations are associated with an increased risk of breast cancer, but also ovarian cancer. I also just want to point out that those are not the only mutations that a woman with a strong family history or an early diagnosis of breast cancer should be thinking about. There's a whole panel of many other genes now that we test for, and it's equally important that we think beyond just BRCA1 and BRCA2. But with those genes that are associated with a hereditary risk of breast cancer, it is important, particularly if someone is after childbearing age, that we talk about when it's appropriate to take out the ovaries, and that if a woman is younger, let's say 30 years old and hasn't had children, that a real fertility strategy is developed should they want to maintain their fertility and want to maintain their ovaries for a particular period of time. But in general, for women who have no family history of ovarian cancer and breast cancer alone, and have no known hereditary gene that they've inherited, we do not classically advise women remove their ovaries to prevent ovarian cancer risk. The one instance where we do talk about removing the ovaries for otherwise healthy women is if women we talked about hormonal therapy before, endocrine therapy for estrogen receptor positive breast cancer. So one of the things there is that for premenopausal women, we do talk about tamoxifen, but another thing that we talk about is also aromatase inhibitors. These are the drugs that we classically use for postmenopausal women that work to decrease the amount of estrogen that the body can make. And in some instances, for young women who have very large or more aggressive estrogen receptor positive breast cancers, we do talk about rendering them postmenopausal and stopping any production of estrogen. Sometimes we do that with a shot, a monthly shot or 3-month shot, which we refer to as Lupron. And in some instances, the need to persistently obliterate really the ability of the body to make any estrogen that could stimulate a tumor, we advise removing the ovaries. So that is probably the only other instance that we talk about what we call a bilateral salpingo-oophorectomy, which is basically removing one's ovaries. So aromatase inhibitors versus tamoxifen for postmenopausal women. That's a great question. So I was gonna draw you another little cartoon, but I won't. So let's imagine that the outside of the cancer cell has a door to it. Okay, it has a door to it and has a big keyhole in it. And that keyhole is for the estrogen receptor. That keyhole is the estrogen receptor. And in order for the cell to be stimulated, that door has to be opened so that the estrogen can get in through the door and stimulate the kitchen inside, okay? The center of the cell, the nucleus, to help it grow and divide and multiply and multiply. So when it comes to that keyhole, there's 2 different ways that we can stop that door from being opened. You don't want that door opened. You don't want estrogen getting in. One, you can put a piece of gum into that keyhole or cement it over and just say, I'm going to block anything from entering that keyhole. And that's essentially what tamoxifen does. It does not block the production of the keys. It does not block the production of estrogen. It blocks the ability of estrogen to enter a cancer cell by blocking the keyhole. It's what's called a selective estrogen receptor modulator, which means, or antagonist, which means that it blocks the ability of estrogen to enter the cell. Classically, this is what we use for premenopausal women. Some of the side effects that are well known are hot flashes. That's one that's really debilitating for some women. Sometimes we use an antidepressant called Effexor to help with those. Acupuncture can sometimes help a lot as well, but we recognize that that's a very frustrating symptom that women can experience. Adverse or more serious side effects from tamoxifen that are quite rare but still can happen are an increased risk of blood clots. So someone who has a family history of blood clots would never be put on tamoxifen unless that was worked up and found not to be a risk factor for the patient. There is a very slightly increased risk of uterine cancer, particularly in postmenopausal women who take tamoxifen. That risk is probably less than 1 in 1,000 and really found predominantly in women who are overweight and postmenopausal. I'll get back to when we use it for postmenopausal women, but aromatase inhibitors are classically what we use for postmenopausal women. And how aromatase inhibitors work, aromatase is an enzyme that helps the body make estrogen. So aromatase inhibitor means you're blocking the production of estrogen. So you're not blocking that keyhole to the door, you're blocking the number of keys that can be made, the amount of estrogen that can enter the cell and stimulate it. So what are some of the side effects that we see with aromatase inhibitors? Joint aches are common, vaginal dryness is common, which we can usually help women out. There are different modalities that we really try to work on for women, including sometimes even giving them local topical estrogen inside the vagina to help with vaginal dryness and discomfort. There can also be a decrease in bone density. And this is something that needs to be monitored quite closely, often yearly. And sometimes we need bone agents, bone strengtheners to help women with their bones. So when might a premenopausal woman do an aromatase inhibitor, and when might a postmenopausal woman do tamoxifen? So sometimes a postmenopausal woman can't tolerate an aromatase inhibitor, or they're very worried about their bone health, or they have a lot of joint aches. And in that instance, sometimes we do use tamoxifen for postmenopausal women. It is slightly, very, very slightly less efficacious than using an aromatase inhibitor at decreasing the risk of breast cancer coming back. So really, if a woman cannot tolerate an aromatase inhibitor in the postmenopausal setting, and we want to be able to give them something, tamoxifen is often an excellent choice and often does not have the same type of bone aches that an aromatase inhibitor will. Why might we give an aromatase inhibitor to premenopausal women? We can only give it to them if we render them postmenopausal, either by removing their ovaries or giving them a shot. And the reason for doing that is in some instances, women have more aggressive estrogen receptor positive disease, and we want to really, really decrease the amount of estrogen that can stimulate a tumor. So another question about whether bisphosphonates have a role in preventing bone metastasis in breast cancer. So there is some evidence that that they can help. So that data is still really evolving. And what we say is that if a woman has a need for one of these medications, such as osteopenia, which is bone thinning, or certainly osteoporosis while on an aromatase inhibitor, we're definitely going to be talking about introducing a bone agent to maintain their bone health, and in some instances, potentially decrease the risk of bone metastasis. So that's a great question and a great area of research that is ongoing. Another question that came up about how far away are we from using liquid biopsies in breast cancer? So what's a liquid biopsy? So I talked about before that when we really want to understand how a breast cancer, what's causing it to tick and grow, we talk about sticking a needle into it, right? And taking out a piece of that tissue and looking at it under the microscope, whether it's an oncotype test or other tests that we might run, particularly if somebody has metastatic disease. But one of the frustrating things is that's always not so easy, particularly if the cancer is not in the breast, but has spread to another part of the body. And it doesn't allow us, for patients who have metastatic disease, we're not constantly going to be biopsying them over and over and over again. I mean, that's stressful. It can be painful. We try not for it to be, but that's a real, lack of a better word, terrible nuisance on patients' lives. So one of the things that we really want to do is be able to monitor the blood for any cancer cells that might have tipped off from the primary breast, or if a woman has metastatic breast cancer, as a way to monitor how she's doing with that treatment. So in the early stage setting, why would we use a liquid biopsy? Because one of the most common questions I get from early stage breast cancer patients, if they've done chemo, hormonal therapy, if they've gone through everything and all the PTSD that comes with it, and then they have this anxiety every time. Well, how do you know that I'm cured? How do you know? And I can say, well, statistically, we've given you everything, and this is, your odds are this and that, but I can't really tell in this black Pandora's box of what is the actual what is actually going on in that woman's body. And a lot of times they'll say, well, why can't you PET scan me? Why can't you CT scan me? Because by the time you PET scan or do a CT scan, if a woman does have metastatic disease, it's grown to form something. It doesn't pick up micrometastatic disease. So liquid biopsy in the early stage setting, the goal of that would be to take a blood sample and see if we can pull out any cancer cells from that. And that's something that I'm working on with a colleague of mine, Sohel Tavazoy at Rockefeller University, who's developed a lot of these techniques to try to develop a blood test to predict and help capture when women have what we call micrometastatic disease. And the goal of that would not be only to capture the cells, but take them out, study them, and say, oh, these are just dead cells floating around, or these are active cells that are that have a passport to the lung or they have a passport to the liver. How do we block this before it ever becomes a problem and continue to render the patient cured? And for metastatic patients, it would really be helpful to say, rather than imaging them every 3 months, to say, you know what, every month we're going to bring you in for a blood test. And when we do that, we're going to be able to monitor the burden of disease in your body and see if that goes down as we give you a new treatment. Or if the cancer is mutated, we can see that, go around that mutation and fight that cancer off. So in terms of how much we use these, already we're using them for metastatic patients. So there are different types of tests being offered at different academic hospitals. We use it all the time to try to monitor patients' cancer. A lot of times they're part of clinical trials, but there are some conventional tests that we do use as part of academic centers. Another question is, can breast cancer spread even if you don't have breast lymph node involvement? So it's a great question, because when we look at the history of breast cancer and how it's been treated, many of you may have heard of the concept of the Halsted mastectomy. The Halsted mastectomy was a very disfiguring surgery that a famous surgeon did, where he basically took out, if a woman had breast cancer, the entire breast, the muscle underneath, sometimes the rib cage underneath, and almost all that he could scoop out from underneath the armpit. Women were very disfigured. They often had massive lymphedema and no use of that side of their body. But the idea was, well, I'm going to take out every possible thing wherever this cancer could spread, regardless of whether the lymph nodes seem to be involved. And what Bernard Fisher, which was a doctor later on in the 50s and 60s, figured out was that even when Halsted did that, there was some percentage of women that still had breast cancer cells that spread regardless of whether their lymph nodes were taken out or whether they had lymph node involvement. So yes, breast cancer can absolutely still spread even if you don't have lymph node. Your risk of breast cancer spreading is higher if the lymph nodes are involved, but it's not nothing if the lymph nodes aren't involved. So your doctor will help calculate that risk based on things like Oncotype score, which is what we use for estrogen receptor positive breast cancer patients, or calculate that risk based on the size of the tumor. Because a woman could have a very large tumor in the breast, but no lymph node involvement, or a teeny tiny tumor in the breast and lots of lymph node involvement. So it really depends on how the cancer is behaving. And while the lymph nodes are helpful, what we find is that biology, the way the cancer behaves, trumps the anatomy, meaning just looking at where is it and what places of the body might it be. Some other things I wanted to touch upon. I mentioned triple negative breast cancer and a lot of work that's being done with immunotherapy in that context. There were some questions about hysterectomies and whatnot. Remember that hysterectomy is removal of the uterus, and then that's different from removing the ovaries. And I touched upon the times in which we would consider removing the ovaries. One thing that I really want to encourage everybody to remember here is that while we're focused on breast cancer, particularly in a pandemic when everyone's worried about going to their doctor, don't miss your regular screening for other cancer prevention. So pap smears if you're due for them, colonoscopies. These are screens that save lives and are as important as mammograms and all the other things that we try to do to decrease the risk of breast cancer. So I think I touched upon a lot of the questions. You guys, I want to congratulate you for holding your attention, but I don't know if like half of you maybe left because you were like, oh my gosh, there's no slides and I'm tired of looking at it. By the way, this is a patent. I'm in my son's room. These are patents of different inventions. He's into it. So hopefully I was able to sustain your attention. It looks like 30 people are still on, but I'm willing to answer any other questions that you might have.
Great. There were some questions that came in beforehand that maybe you can touch on a little bit. So can you talk a little bit about lobular breast cancer, its detection and treatment?
Yeah. So remember, where's my little picture here, right? So lobular breast cancers, now I do wish I had made slides, I'm sorry. So that's the little green sacs, right? So little green sacs of grapes then funnel into the duct. So lobular breast cancers are the second most common type of breast cancer. They're usually detected on also on imaging as well, mammogram, ultrasound, in some instances MRI. When do we do MRIs? I just want to pull that up for 1 second. So if a woman has a greater than 20% increased risk, lifetime risk of breast cancer, and that's really the threshold for when we think about doing MRIs, for screening. So a lot of people sometimes ask that, and that's calculated by your doctor if you have a family history, et cetera, et cetera. So again, lobular usually picked up, it starts in those lobules, picked up on imaging, or a woman can have a palpable mass. But one of the key things to know about lobular breast cancer is that almost always mainstay of treating lobular breast cancer is hormonal therapy. Invasive ductal carcinomas can be estrogen receptor positive, estrogen receptor negative, HER2 positive, HER2 negative. But lobular breast cancers almost always are hormone receptor positive, which means that they are really respond beautifully to hormonal therapies. And that's whether they are in the early stage setting or in the late stage setting. And it's less often that we are using chemotherapy for estrogen receptor positive breast cancers. How long have I been studying breast cancer? A long time. I'm wearing a ponytail, maybe that makes me look younger, but I graduated college in 2000, so a long time. And I was studying it in college too. My senior thesis was all about breast cancer, and I worked at Dana-Farber then from freshman year on.
So there's a question that came in earlier about the fear of recurrence.
Yes.
And I just want to tack something onto that. So when should early stage patients start to worry? Because, as you know, right, when someone's diagnosed with cancer, any headache, any pain in the big toe is, it causes us to fear that the cancer is either coming back or it's spread. When should people begin to worry?
Worry is such an interesting concept because we all have different thresholds for when
Right.
we worry, right? And I wish I had a magic pill. I talk to my children when they go to bed at night, give me your worries, I'll put them in the worry tree. And I wish that I could do that for my patients because the worry is almost worse than the diagnosis and the treatment. How you move forward every day. If I tell somebody you're a 99% chance of this never coming back, some women may be able to swallow that and say, oh, that's great. But for other people, that 1% will keep them awake every single night. So worry is, I salute all the amazing therapists who help people move forward one step at a time with the fragility of life that we all have, right? But in terms of what we worry about for actual symptoms, so a couple things that patients should think about. If you have a new pain that is new and getting worse, and not going away. Most of the time it's nothing, okay? You're allowed to lift your suitcase. I mean, who's going anywhere lately? But lift some luggage and your back hurts, or a piece of furniture. Back pain is the most common thing that happens. Or a cough because you have postnasal drip or an allergy. But if you have a new cough and it is getting worse and it's not getting better over, I would say, a 2 to 3 week period, call your doctor, give them a call. Again, most of the time it's nothing. If you have a new pain anywhere in your body and it's not going away after 2 to 3 weeks and you've tried some Aleve and you're worried about it, give your doctor a call. But I would also say beyond that, really use your mental health experts because they have techniques far better than I do for how we manage the plague of worry, which I know that so many people are feeling right now, particularly in the context of COVID and the isolation that it's causing. Should I look at this other question?
Yeah, I see that new.
Yep. So it's a great question about how reliable are mammograms and sonograms, and when should we be getting MRIs? So again, there are some instances where MRIs are really the best way to pick up cancers, and we are still working on, we don't do MRIs on everybody. Part of the reasons why we don't do MRIs on everybody is they're very, very sensitive, but if we just took the whole population and did MRIs on all of them, most of the time, all these tiny little things that we'd see would turn out to be nothing. They did a study on that. And what happened is so many women were getting biopsies and biopsies and biopsies and having false positives from these MRIs. And that caused a tremendous amount of worry because God knows you get a biopsy, you have to wait for those results. So there are different thresholds when we meet with a surgeon and a radiologist who helps us determine who are the women that really might benefit from an MRI. They tend to be women with younger or dense breasts or a very strong family history. And it's not uncommon in those instances that we alternate with an MRI, a mammogram, and a sonogram.
So somebody is asking about interpreting their pathology report
Yeah,
after surgery, and we get some calls on our helpline about
yeah,
trying to help people interpret that. It's words that people don't understand,
yeah.
and sometimes it's not fully explained.
Mhm.
Any, I know that there's some good information on breastcancer.org.
Yeah, so breastcancer.org is really helpful. I would say that the key words to look for are invasive ductal carcinoma versus invasive lobular carcinoma. Sometimes there may be some other words in there, but in general, they'll pretty much delineate what type. The estrogen receptor is really key to understand. Um, DCIS will also come up in a pathology report. That's the pre-invasive cancer that we talk about. The cancer, the cells that, if left unchecked, might turn into a more invasive cancer. That was that original picture that I was showing here, where the cells start to grow inward. And then you may also see words like atypical ductal hyperplasia. This is even before DCIS. Atypical ductal hyperplasia means cells that are just growing slightly abnormally, but they're not ductal carcinoma in situ. They're not invasive ductal carcinoma. Those are some terms that you might see, because when you take out a cancer, you may see the trail behind it, the precancerous cells, the DCIS, the ADH, atypical ductal hyperplasia that may also be in the soil there. Other things to look for are how many lymph nodes were taken out and how many lymph nodes were involved. That becomes really important. One other thing that you might see when you look at the estrogen receptor and progesterone receptor is you'll get a percentage. So what was the percentage activity of the estrogen receptor? Was it 90%, 100%, 0%? That helps you determine whether how strongly someone's receptors are. You may also see a HER2 score, which is 1+, 2+, or 3+. 3+ means you're positive for the HER2 receptor. 1+ means you're not. 2+ means you're right in the middle. And you might get a test called the FISH test. The FISH test is an additional test that they do on the tumor to determine, are you really HER2 positive? And when you get that score back, what you might see is that you're amplified. I mean, it's like, why did they come up with all this? Amplified or not amplified? HER2 amplified means that you have the HER2 receptor. HER2 non-amplified means that you don't. One other question, can metastatic women skip mammograms? Almost always, yes. I would say 99% of the time, yes. And then with respect to radial scar, that's really a surgical question. Sometimes it's removed, but you really have to see a surgeon about that to review exactly where it is and what are the surgical options for you.
I think you touched on this briefly, but I'll ask it again. Oh yeah, someone's asking about the radial scar, sorry. What medicine do you recommend for people that have very severe hot flashes or night
Mm,
sweats caused by an aromatase
yeah.
inhibitor?
Yeah. So, or tamoxifen. So, for an aromatase inhibitor, you have a little bit more options in terms of the antidepressants that help, but for the most part, Effexor, which is in higher doses an antidepressants, in lower doses doesn't really have that much antidepressant activity, but can really, really, really help with those hot flashes. So often we prescribe 37.5 milligrams of Effexor to help with hot flashes, because we know that those can be really debilitating. Other women really do well with acupuncture, and that's another great modality. And other women, find that the hot flashes get better over time. But I think really bringing that up with your doctor is important, because no one wants that as a side effect.
And there's just one last question here. Your opinion of Prolia. What are the
Yeah.
side effects?
So Prolia is one of those bisphosphonates, one of those bone agents that we use to help strengthen the bud. I don't know what bud is. Blood, bone. I don't know. I've talked too long, I guess. Some of the things that you have to talk to your doctor about is you have to make sure that you don't have any recent dental work or implants. There is a very slightly increased risk of something which we call osteonecrosis of the jaw, which is it's a degradation of the jaw, the bone there. That again is very, 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 very rare, but you have to see a dentist first and make sure that it's safe for you to get the Prolia. Other than that, the side effects are very, very minimal. And if your doctor has recommended it to you, it's because you need it for your bone strength and your bone health over time.
Thank you so much. And I just want to tell the audience that if we did not get to answer your question, please call the SHARE helpline. We have an amazing group of volunteers on that helpline who are very, very knowledgeable and can guide you to the right answer. Dr. Comen, thank you so much. This has been so fabulous. You are fantastic. And I'm not the only one that's saying that. I've gotten a bunch of texts, people who are listening live. She is fabulous. This is so informative. Thank you so much.
Well, I'm
you
glad.
are the best.
No, I'm glad it was helpful. Next time I'll come with better cartoons.
No, we like your drawings. We
Okay.
really like your drawings. So everyone, thank you so much for joining. If you wouldn't mind just taking a survey at the end of the webinar, that helps us to create additional programming for you. Thank you so much. Dr. Comen, again, great to see you.
Nice to see you too. Be well.
Thanks everyone for joining.
Bye.
Bye.